Holmes-Henry. I'm Cherie Holmes-Henry, and I'm happy to be on this committee and also on the WEDI board. My big job responsibilities, I'm over government and industry affairs for NextGen healthcare, and electronic health record. I also am in the past chair of the Electronic Health Records Association, or EHRA. So for WEDI, I wear a number of hats, but one is that I represent the HR vendor community. And I'm happy to talk about today. And I didn't have a chance to pull together any slides. I'm just coming off of our annual first time back in person user group in Nashville, and then had some time off this week. So I'm scrambling big time. But Ed had asked me to talk about what we're seeing, especially with payers and providers and with technology, in terms of how it's having to address the issue of managing risk and managing chronic care patients, and the overall concepts of case management, care guidelines, chronic care management. They have lots of different terms and concepts. And to talk a little bit today about what we're seeing from an IT perspective in terms of different tools and software and products and services that really are designed to kind of support the managing of risk as we move down the path towards value-based care. So my plan is to try to just give some overview concepts and then obviously open this up for a Q&A dialogue. I know we have some pairs on the call as well, and hear their perspective and see where we go from there. So first of all, as I'm sure most of you know, payers have been trying to manage risk for, insureds for quite some time through various means and various programs. And if you've ever been to a RISE conference, RISE, or anything like that, there have been a number of tools that payers have developed over the years to try to organize and identify those high-risk patients, those that obviously are, use the most services, file the most claims, and have the most exposure in terms of overall insurance coverage from a risk perspective in terms of a loss ratio. So, one of the challenges to start with is just identifying kind of who those patients are. And so payers have developed a number of tools over the years to do something that's called cohort management. And that's really beginning to understand based on the providers that contract for certain health plans, especially things like Medicare Advantage plans or risk-based programs, whether it's managed Medicaid, like we see with Centene's plans, our overall an accountable care organization, or some other value-based care model, who the population is and what percentage of the population has how many diagnoses and types of risk, and then how to organize and manage those cohorts or population. So there are a number of tools. Payers have developed actual portals that they have make available to physicians to ask them specific risk assessment questions and profiles and screening tools. Often they're pretty arduous and long and lengthy, and providers have to dedicate resources to fill those out. There was also the day, and it still occurs some, but not as much, of the actual chart pull, where the payer will send out a third party, companies like Ciox and others, to physically go into, it used to be the old paper file, but certainly now into the electronic health record, and uncover certain types of demographic information as well as other kinds of information to really determine details on those given patients. And obviously, in the long run, what the payer is really trying to solve for is something that we often hear the term gaps in care. So, when that patient is presenting and they need to have, their colonoscopy or their mammogram or whatever, are there tools in the EHR or ways that the provider is alerted to make sure that they're closing those gaps and they've met those requirements that the payers are actually dictating or requiring. And it's not just the payer, it's whether they're, using HEDIS measures as our NCQA guidelines, are there in patient-centered medical home program, or a number of programs. I mean, they're always looking for and identifying how do you manage chronic care patients and how do you ensure that you're remediating those gaps in cares. One of the challenges is that these portals actually require the provider to not be able to really address these issues in their workflow, because they have to go in and out of their EHR, have staff, perhaps a care coordinator or care navigator that's actually addressing this information and doing follow-up on that, or do some kind of integration with these portals, are an actual API. We're seeing, a number of new tools really kind of evolve to try to get that more at the point of care. But it makes sense if there are alerts that tell you the day before a patient is coming in, that these are the list of things that you need to look for, and how do you really manage that? And once you've accomplished those tasks, how do you then check that off and report that back to the payer, so the payer knows that you're meeting the guidelines of a specific risk contract regarding that level of coordination. So the other tools that we often see from an IT perspective are different analytics, our population health tools, both those that are used by the payer, those that are also used by the provider, those that are either a part of an EHR or a third-party add-on to an EHR, those that have come in and in some instances are contracted by the state. For example, under state Medicaid plans, the State Health and Human Services Agency, our various state primary care organizations will use a specific tool to try to analyze the population and determine, what patients really have multiple chronic conditions and which patients would fall into some kind of patient-centered medical home program for a level of coordination of care, or some kind of a chronic care management program. CMS several years ago implemented regulations for specifically Medicare chronic care management, very, very heavy lift regarding the kind of screening tools and the data that had to be captured to identify this level of risk and who these patients were, and then how to manage them. And then an element of how that then gets assigned to a care coordinator or, a nurse practitioner or care navigator to then manage that risk. And then on the back end, report out on that. In that arena, we saw a number of third-party products being created and developed that were chronic care management software that were either integrated into the EHR or licensed and sold separately, both tools that were sold to the payer as well as tools that were sold to the provider. The early success of those tools was not very effective, as a lot of providers really hesitated signing up for Medicare's chronic care management program because the burden to document, the burden to get the patient to sign off on a consent, the burden to track the hours and the time that it required to do all this care coordination, the burden to add additional care coordinators and develop workflow and develop care guidelines and all the tools that went with it, outweighed the actual reimbursement level or the additional incentive that they were getting. And there was also a real fear of being audited for Medicare fraud because the level of documentation that was required and the differences in the billing requirements made a lot of providers skeptical. Well, this is just another way that, CMS is trying to audit me or get money. Since that time, CMS has made some significant changes to those regulations and has come back around, and we're seeing more and more organizations either adopt the program or modify those regulations to commercial payers and to other initiatives that have similar requirements. We've also seen the advent of state requirements, especially around managed Medicaid, are really at the move to an APM or an accountable care organization for a value-based care model. The two biggest being California with their CalAIM program, and Massachusetts with something they call C3, which really takes the requirements of CMS's chronic care management and literally is kind of puts them on steroids in terms of implementing those programs. In California, it's very interesting because you have a kind of a Kaiser model, and then you have a number of other commercial players that are contracted with the state to deliver services. And they, first of all, start with attribution in who gets assigned what patient, by zip code and by county. And then they assign that to an organization such as a federally qualified health center to deliver that care. And what we're seeing in this model, and it all, brings in how do you identify the cohorts of chronic care management patients, and how do you then manage that risk and manage that cost. And even to the point that it includes mental health as well as social determinants of health. And in California, in many aspects, we're hearing what's called street medicine, where so many of these patients are actually homeless, which present tremendous challenges. And these care coordinators actually, through a mobile app, in different levels of technology on their iPad or something that's a mobile device, are providing care in a shelter or at a hotel that the state or the city or the county has contracted with, for services for patients that are very transient. And as you can imagine, that provides a number of significant issues and a number of needs for technology to be able to manage care in very different kinds of settings. So that's kind of the landscape. The other tools that we often see are things that are called care guidelines. Those often are tied and often come from medical societies for specific specialties tied to specific diagnoses that give best practices and clinical decision support tools, which are often, embedded into software. And right now we're dealing with one of the issues on guidance from the FDA, once again, whether or not those tools are seen as a medical device and additional potential regulations for that, should that be so deemed. But these guidelines will help provide the provider, best practices and paths for treatment. It also is an attempt to try to manage referrals. And there are software and tools and IT resources around the management of referrals. We're also still trying to work through some standards as it relates to referral management, the 360X program, which really coordinates care and manages within one of these risk-based models the actual risk that's occurring, what providers are in network or not in network, and what is that whole person care approach. Are you treating both, the physical, the social determinant level, as well as the behavioral health elements of that care that's required to make sure you get the best outcome? And then on the back end of all of this, there are changes in billing tools as well as in coding. And there are also changes in reporting. Both the commercial payer, Medicare Advantage, CMS, Medicaid, the state, all of them require results, both in the terms of HEDIS measures and other quality measures on a quarterly or an annual basis to determine the ratings, if you're under a star rating program, or actual reimbursement, and then how you're then contracted with for succeeding years after you've kind of been in this program. Now, to the patient, they too can participate with software and tools if they have the means. And that's often a challenge, for example, in like the patients I described under the street medicine model. But oftentimes the patients are interacting in these programs through the use of patient experience activities, including patient portals, which allows them to, obviously get a prescription refilled and manage their prescriptions, ask a question of their provider, schedule appointments, and even access their actual medical record to be able to, provide interaction. We certainly see a lot of consumer advocacy around chronic care management of specific disease types for certain types of patients, whether they're cancer patients or MS patients or Parkinson's patients or others that have long-term chronic diseases that require a lot of advocacy and coordination to try to make sure that they can seek the best outcome and the best quality of care. There have been a number of apps as well as again, specific consumer-facing tools to allow the patient to be more engaged in their care, and especially those patients that have chronic care diseases and are oftentimes needing to advocate for themselves to try to ensure. We're beginning to see some movement around patients that have long COVID for the same thing, just challenges in getting diagnosed, challenge in getting any kind of proper relief or care, and challenges in services being denied, our continued requests for prior authorization for approval for different types of diagnostic tests, all of which can be, supported by different levels of technology to support both the patient themselves as well as the provider and the payer. And so all of the stakeholders in this continuum have an element of a need for care coordination and IT specifically to support these programs. So that's a lot. I'm going to leave it there for a minute and have Ed help engage and let people either talk about their own experiences or tools that they use or ask any specific questions.
All right, Cherie, that was awesome. Questions for Cherie? And don't be shy. We're a friendly group. And Cherie, I wrote down questions. I always write down questions kind of to hopefully tease out others. So just raise your hand if you like to talk, and it's just go down to your my goodness reactions, and then you can raise your hand there so we can make sure we catch you if it's tough to come in, or feel free to come in through the chat as well. Cherie, it's interesting. Golly, I'm going to let Denny go first. Go for it, Denny.
Hi, Ed. Thank you.
Sure.
Cherie, there's an awful lot of technology and an awful lot of business process redesign that's in place to accommodate or adapt to the absence of data standards, data liquidity, more patient access to their health data. And we're moving toward, with regulations and just technology advancement, we're moving toward a world where more and more of this information is going to be more and more available to the people who should see it, especially the patient or the member or the person. What do you think this opening of the data floodgates, this loosening of enterprise strictures around data, what kind of impact is that going to have on technology, and where do you see technologies benefiting from this, or what technologies do you see benefiting, and what technologies do you see being, having to reset or reorganize themselves to meet this new world?
Great comments and questions, Danny. I appreciate it very much. Obviously, data privacy kind of permeates all of this. And we certainly believe that both, the needs to modernize HIPAA and the needs around even the sharing of data in an accountable care organization that, was prohibited at one point, and we had antitrust issues with all of that, have to be looked at and addressed. And that's being covered by, some of the potential legislation even proposed in Congress today. We also are very aware that obviously once the data leaves the four walls of the EHR and goes out into the app community, regulated by the Federal Trade Commission, that's not covered by HIPAA. And there's been quite a bit of activity and both concerns and advocacy around what to do with that. For example, the Karen Alliance is really very supportive of the consumer and the app community in trying to normalize that data and deal with the privacy issues that occur, when you're outside of the EHR. There are still challenges for patients to really understand this and to be able to, kind of read the fine print to know whether or not their data can be monetized or not. But there certainly is, a growing need to be more aware and certainly participate. In all of this, we also are looking at an additional level of standardization, as well as the need for data segmentation. One of the, tenets around the info blocking rule and cures and beyond, where we are now is that the US CDI v1 has moved to, kind of full EHI. And that definition is still somewhat unclear, although it follows the HIPAA designated record set. So EHR vendors can only share data that they actually have. So there is a determination of whether or not an element is missing or an element needs to be required based on a certain program. And I think it's going to take time over the next few years to really look at what the definition of EHI is and what patients are really going to be requesting. But there's been controversy, as I'm sure many of you know, especially from the provider community, around control of that data, especially sensitive encounters, whether it be mental health related or HIV/AIDS or other situations around diagnosis without actually providing guidance from the provider to the patient and just, for example, posting it on the portal as some of the requirements for the info blocking rule have. There have been state exceptions like in California and others, but still great concerns of timing of when to share, what to share, how to share, especially those sensitive encounters and information where the provider community feels very strongly that they need to provide guidance on an abnormal lab result or guidance on a terminal diagnosis or specific issues. And hospitals, for example, have specific concerns regarding release of labs and certain things that are under the info blocking rule that they would like to still find ways to maintain control.
Okay.
Thank you.
Okay. Thanks, Danny, for the question. Cherie, I could see this really working much better in a collaborative value-based care type of arrangement. In a fee-for-service one, I would think it'd be a little harder where there's not quite that kind of a tight relationship between the health plan and the providers. Can you talk a little bit about those dynamics?
Yeah, and that's absolutely the case under the fee-for-service world, which is again where Medicare is trying to move us away from. You don't have the access to the data. You don't have the access to even the provider assignment for the patient. The oversight organizations don't always know until there's a claim filed. And you certainly don't have the incentives or the contractual guidelines or agreements to pursue these programs that I just discussed. It's very open. The patient can see whatever provider they want, and the provider is just purely doing, kind of traditional services and traditional billing without all these other requirements. So that provides limitations. So when you hear, HHS announce and CMS announce that their goal is to get every patient in an accountable care organization model by 2030, that's an economic impairment for the state of Medicare and the financial situation that we find ourselves in terms of the aging population, the aging baby boomers, all of that, and the limited resources, both in terms of financial as well as care delivery models.
Right. Yeah, thanks. I'm thinking also on that trust part that you talked about between provider and payer. You mentioned, of course, the Medicare example where, gosh, they could be audited, right?
Yep.
Right. But there's also other kinds of trust issues on the kind of care programs that a health plan might require. And I think you've also, just mentioned that the providers, of course, like to have some control on the care plans as well. Can you talk a little bit about those dynamics and how that's evolving?
Yeah, I mean, this only really works if you get trust from the patient and participation and confirmation from the patient. One of the serious problems, especially in these Medicaid programs, is digital literacy, access to broadband, access to technology to even be able to to read the consent form or to understand it and agree to participate. And then most of these programs require a pretty extensive screening that's done around either in person or online. And they use telehealth services and a number of things, but the questions are, some of these documents are 7 pages long that go deep into not only demographics and financial and socioeconomic, but obviously mental health and STOH, and are oftentimes, even in themselves, the screening questions are very sensitive. So getting patient participation and cooperation to both answer the questions, share the information and provide it, and then knowing what to do with it have been quite challenging.
Yeah, the SDOH plays really interesting here too. Is there any other thoughts you have on how to or those that are using successful practices and integrating SDOH with risk analytics?
Yeah, a couple of things here. First of all, is still the codification, through the Gravity Project, which has just recently gotten some additional funding. We're trying to get ICD-10 codes to actually codify, though, once you screen what, if you're looking at housing insecurity or transportation or whatever, and you codify that so you can report on it and do something with it. And then the other is the overall remediation. There are third-party companies like Unite Us and Find Help and others that offer services, but these services are so regionally and locally derived and based. It's really hard to maintain those databases and find ways that the actual providers themselves and the payers are actually, contracted with and can use those services. And then technology is deployed to not only identify it and code it, but then identify resources, for whether it's a food pantry or, a lift service or whatever, to then coordinate those remediation services with the patient, and how that then ties back into that risk score back into the payer, that you've taken into consideration, not just the clinical issues that you're addressing, but again, those other non-medically related factors that are affecting outcomes.
Okay, thank you. Other questions, make sure you raise your hand or type it in the chat. I just have a few more, so I want to make sure we keep Cherie's good flow of information going. So it's up to both of us to do that. Risk analytics is to me is one of the okay. Well, before I go to risk analytics, Brian has a question about TEFCA. The promise of TEFCA and being able to exchange that clinical data and all. Do you have some comments about that, Cherie?
I do. I mean, I think, obviously one of the long kind of pillars in all of this is a way to share and receive information on a coordinated care basis. So just the ability for a provider to know that a patient was treated somewhere else or discharged from the hospital or had another procedure that, didn't come through them is critically important. So whether it's using their current frameworks through care quality or Commonwealth, or whether they're in a state or regional HIE, what the promise of TEFCA is really truly creating that national framework and common agreement where data is more appropriately shared and is more usable and accessible to the provider, and in a way that it's usable. Right now, there's still a feeling that the CCDA contains far more information that the individual provider really can absorb or use or pull down into the EHR, and there may be very specific data elements that they're really looking for. And the promise of TEFCA is, how will that really get addressed? California is then followed suit by passing a piece of legislation called AB 133, which is a data exchange framework. And we're calling it kind of Cal-TEFCA. It's their own version of the national framework. And this really came as a result of COVID, where they were so challenged with the volumes that they had to get access to the data they needed for national reporting. It also is a tie into the CalAIM program that I talked about, which is the value-based care model for Medi-Cal. Again, California being the largest coverage for Medicaid in the country, and a need to coordinate care and have that data at the point of care in a manner of knowing, again, if they're seeking out-of-network care or have been hospitalized and discharged, but the treating care coordinator provider is not aware of that. So interoperability in and of itself will play a role from a technology standpoint in all of this. And then the other one is continuing to manage referrals and having that information when you provide that referral.
Okay, thank you, Cherie. Okay, well, we got thanks from Brian. Hey, risk analytics has always been very intriguing to me. Being able to identify patients that have chronic conditions, even possibly using machine learning to predict risk conditions that are forming, or engaging the provider to be able to to investigate, or discovering gaps in care, perhaps not just from informing the provider that there's a gap in care, but also the other way, where there's a new risk condition that the provider has discovered, and getting the health plan engaged. And it's just an interesting circle how as a partnership you can truly hopefully be more proactive in taking care of the patient. Thoughts on that topic?
Yeah, I couldn't agree more. And I'm not sure if that they're a member, but companies like Inovalon, that's really the business space that they are in. And I'm sure there are others as well that really have used AI and machine learning to create various algorithms and models to try to identify, risk components, both for, in working with their payer clients, as well as, their self-insured employer clients, as well as HIEs themselves. And, being able to really, create an algorithm that really crunches large volumes of data and look at trends and patterns, I think will continue to be both a benefit and a need as we have growing volumes of data.
Thank you. I totally agree.
And I think change may also have something similar.
I wasn't going to say that. Okay.
Yeah, but I can.
Okay. All right. You mentioned, the software that recommends procedures and follow-up, activities towards,
Clinical decision support software.
decision support. There you go. Yeah, just really interesting, and maybe a little further detail on some of that integration and how that plays in these models.
Yeah, and again, EHR vendors have to be very careful in terms of how they use these tools, and they have to be very appropriately vetted and all that. But Walters Kluwer and First Data Bank and others, there are other organizations that also create care guideline tools and clinical decision support tools, and they have to be used within the workflow that makes sense, that is not intrusive to the provider, but provides them a guide for best practices. And if they're especially if they're working with a chronic care patient and they're trying to research options for developing an actual care plan for how to treat. And also these tools are used also in diagnosis, especially for certain chronic care patients that it's very difficult to diagnose. I mean, long COVID being an example of that, where it presents with so many different symptoms that could lend themselves to different kinds of diagnosis. We're seeing a number of tools actually being developed when you have chronic, kind of immunocompromised diseases such as this. So, but it all needs to be trusted by the provider and feel relevant, and work within their workflow, so that it doesn't hinder how they're used to following a care plan.
Right. Okay, cool. Thank you. And my last question that I have is really relates to NextGen and your play and the different sorts of, I know you're not supposed to promote ourselves, right? But interesting that from a successful practices perspective and some of the cool things you're doing in this area, it'd be really kind of cool to hear about some of that functionality that NextGen might have.
Yeah, and the timing is great because we're just coming off of our user group where our theme was better healthcare outcomes for all.
Okay.
And we actually gave awards to our clients who are using different innovative ways that they've used the software or used a combination of tools and software to achieve better outcomes for all. So that, we're in an ambulatory space, so not a hospital space. And we have defined, 26 kind of defined specialties. And so it will vary by market and by provider type that we support. But the overall theme is how through use of the technology and a lot of the things that we just discussed today, can they achieve, it's not just their reported measures for MIPS or for promoting interoperability, but, how do they rank against their peers? So we're doing a great deal of work around insights and what we're calling a collaborative to have our clients share their data, de-identified data. How can they measure their outcomes and the results against their peers? And with doing that, how can they improve their scores? How can they improve their outcomes? And how can they continue to kind of raise the bar?
Interesting. And would you mind talking about some of those, maybe some examples, maybe not by naming the organization, but of some of those cool success stories of using technology in a unique way? Would you mind sharing?
I don't mind sharing. I just don't probably have the data points at my fingertips today, Ed.
Okay.
I've got some material though that we just recently released that I can share to the group.
Okay, very cool. It might be interesting to bring someone on and if they're willing to talk to us, that might be fun.
Sure, one of the clients.
Yeah, that'd be great. And if there are other vendors on the call today, we are looking at your customers and unique ways in which you're using technology to solve their business problems and better health. And so if you have those examples, please make recommendations to me. And you should be able to see my email, but if you don't have it, it's edward.hafner@changehealthcare.com. And feel free to email me if you have any ideas of one of your customers. We can't promote you but we can promote your customers doing some very cool things. I'd like to see that happen more.
I also, Ed, as Charles wasn't able to join the call today because he was coming back from the health conference. That's HLTH, no vowels in that name. So I'm very interested in talking to him and hearing what kind of innovations and things did he learn from that event, because that's what that conference has really lent itself to. It's kind of a version, almost a mini version of the JP Morgan Chase investor conference that's done at the beginning of the year. And we often will see product launches and obviously a lot of innovative new approaches and tools. So I'm anxious to hear what he learned out of all that.
Oh, cool. Yeah, I'll definitely prompt him. That's a great suggestion, Cherie. That's awesome. All right. Any other thoughts you'd like to add, Cherie?
No, I just appreciate everybody's time with me today.
All right. Well, you were awesome. Yeah, you're full of information and very, very interesting stuff. And it's impacting our value-based care type of programs and bettering healthcare. So gosh, you can't.
And also our work group on SDOH, I think, and health equity, I would say as well.
Right. Yeah, absolutely. All right. Well, thank you all for attending today. And stay tuned next time. We'll try. And if you have any ideas and would like to have us present next, please give us a shout as well. We'll be glad to consider addressing those thoughts as well.
And thank you all and have a good Thanksgiving.
Okay. Y'all too. Okay. Bye.
Thanks, Cherie.